Okay, so let me start. So last day we talked about the basic steps of evaluation or basic steps of clinical methods in evaluation of the any kind of pain. Say for example, if it is a headache, if it is a shoulder pain, if it is a neck pain, if it is a knee pain. So the basic steps are same. So what are those steps? So first is taking the history, general history, then specific history. In the specific history, you should be remembering that there should be certain specific questionnaires for each kind of pain, and that should be asked in the specific history. Then come in the general history, we should be starting with the chief complaint with the duration. Only few complaints should be coming in the chief complaint and with the duration. Then comes the most important part of the whole clinical evaluation process. What was that? That was the history of present illness. So in the history of present illness, we should be having the what is the quantity of the pain. That means what is the intensity of the pain, and that intensity of the pain can be assessed in two types of scale: unidimensional pain scale and multidimensional pain scale. What was unidimensional pain scale? Unidimensional pain scale means we are assessing the physical aspect of pain. How much pain is hurting us physically. Then was the multidimensional pain scale. Physical unidimensional pain scale is measured very commonly by the visual analog scale, by numeric rating scale, verbal rating scale, so all those things. And then comes the multidimensional pain scale. In the multidimensional pain scale, so we are not only assessing the physical aspect of pain, we are also assessing the psychological aspect. We are also assessing how much pain is affecting us in the cognitive ways. So all those aspects are assessed by the multidimensional pain scale. And again, here the most important pain scale is your McGill's pain questionnaire. And then what was there in the multidimensional pain scale? After the quantity, so it was the quantity of the pain, and then there was the quality of the pain. Quality of the pain means the other aspect of the pain. Just a minute. So quality of the pain means the pain, what is its quality? Other, like, whether the pain is neuropathic pain, whether the pain is nociceptive pain. We have discussed last day, there are two major types was there. The third type has been recently added by ISP, and sometimes they can be, that is what nociplastic pain, and it can be a mixed kind of pain. So this is the quality of the pain. Then there was different other aspects like the site of the pains, how there is in radiation or not, what is the aggravating factors, what are the relieving factors. So all those things. Then comes is your family history, treatment history, medical history, personal history. So all those things was there. Another very important part of the history is the psychological aspect. Psychological aspect is also very important. So very frequently this is asked that what is the difference in the history taking about a patient suffering from pain and the other aspects. Means suppose an orthopedicians are also assessing the back pain, or suppose some neurologist is assessing the headache. So what are the difference between a pain physician assessing a back pain or a neurologist assessing the headache? So what are the differences? Very important, two important differences when you are assessing is there are two things basically we are incorporating in our physical examination and the history taking. One is what is the quality of the pain, whether the pain is neuropathic or not. This is one aspect. Why this is a very important addition in our history taking? Because by assessing whether the pain is neuropathic or whether the pain is nociceptive, we are not only going to make some diagnosis, but also at the same time, this is going to help our management part. Means if it is a nociceptive pain, we are going to treat this patient with the analgesics, NSAIDs. If the pain is neuropathic, we are going to treat this pain with some co-analgesics. So this is how it is going to be very helpful. Another important aspect, the new things which must be new means not new in the areas, the psychological evaluation. Psychological is already there, but that part is normally not incorporated in any of the history taking, like taken by the orthopedicians or a neurologist. But that should be the must. At least some basic amount of the psychological assessment should be a part and parcel of a pain physician's evaluation of the pain, because the psychological changes, psychological aspect can be a very important factor which influences the outcome of the management as well as in the diagnosis. So very short psychological assessment should be a part and parcel of the evaluation of any kind of pain. So these are the two very important addition in history taking rather than the other conventional, the specialties when they are also assessing the patient of pain. And after this history, means general history, specific history, we are having the examinations. The examinations in the pain is basically the combination of the neurological examinations and the musculoskeletal system examinations. Like as we always tell that the cardiologist or a chest physician, their steps of evaluation is inspection, palpation, percussion, auscultation. So same way, neurological examinations, the ophthalmologic examinations, all have the different things. So what is the steps? What are the steps of the clinical examinations? Means the physical examinations when it is examined by a pain physician. So it is a combination. So what are the steps? So again, inspection, palpation, a range of movement. The range of movement, we are having the active range of movement, passive range of movement. Then the whole neurological examinations. Then the special clinical examinations. So they are the steps when a pain physician examines a patient of pain. And then other steps are similar, like the investigations. In the investigations also, I told you last day, lab investigations, then your the image, and another very important steps last day we discussed about the diagnostic interventions. That is very unique, but that is very important addition in searching the pain generator. So with that little bit of recapitulation of the last day's class, let us start with the evaluation of the back pain. And above all this evaluation, we should be always remembering that unless we know the causes of that particular pain, we cannot evaluate. Means if we don't know anything about what are the causes of the back pain, how the things looks, how a disease, what are the diseases, clinical features, we cannot evaluated. So before evaluation, we must be having a thorough knowledge of all different kinds of conditions, painful conditions that causes that particular pain. That means unless you know about the different kinds of headache, it is meaningless to examine a patient suffering from headache. Unless you know the different causes of the back pain, it is meaningless to examine a patient suffering from the back pain. So remembering the causes, remembering the clinical feature of that particular pain is very important before we start the clinical evaluation of that part. Same way, in the back pain. So today in the part one of our back pain evaluation class, we are going to cover the different pain generators, common causes of the back pain. And next class, we are going to talk about what are the steps in history and what are the steps in the clinical evaluation, clinical examinations. So, and whenever you're remembering the causes of particular pain, another very important aspect is what are the red flag signs and symptoms. That is also very important. So, we'll be talking about the different causes, and then we'll be going about the red flags, and then we'll be going about these will be the steps. So now let us start. So this was the steps. So just now, as I told, that we should start with we should be remembering the causes, we should be remembering the red flags, and then comes history. In the history, chief complaint, history of present illness. History of present illness again is a long list. Then your medical history, personal history, family history, occupational history. Then starts the clinical examinations, inspection, palpation, range of movement, neurological examinations, and special clinical tests. These are the clinical examination. Then comes the test, and then comes diagnosis and provisional and differential diagnosis. And then last step, which is not mentioned here, is your diagnostic interventions. So this is one of the very important slide. I always tell that if somebody is asked that what is the, the difference when 10 years back or 20 years back with the present scenario in evaluation of the back pain. And if you are reading some of the textbook 10 years back, or even nowadays in some of the specialties, what you will see that whenever the evaluation of the causes or the causes of the back pain is written there, it starts with one very important line that the causes of the back pain are basically mystery, and in more than 80% situation we really don't know what is the specific cause of the diagnosis. And majority of the times this was called as non-specific back pain, but the non-specific back pain is gradually becoming obsolete. Why? This is the present time. Why? Because of the development of the concept of the pain generators. So earlier, this concept was not there. The first publication on these pain generators was in 1999. So in that, what was done? So that was a very important publication. So what was done? So there about 100 cases was taken. Exactly, I don't remember the number of cases in the study, but around 100. Which cases? Which was stamped as non-specific, where specific diagnosis was not possible. And what was done? In that study, they have injected the local anesthetic injections in the suspected areas of pain. Like in that 100 patients, the patient which was suspected as a facet joint pain, the local anesthetic was given in the facet joint, the suspected sacroiliac joint. So in that way, what they found that in those non-specific category, they could specifically identify the pain generators. So non-specific back pain is now gradually becoming obsolete, and you can specifically identify the pain generator with the diagnostic interventions. So this is the present scenario. So in 80%, more than 80% situation, we can identify the nociceptive source. But again, the future, we have to identify the rest all. Means still in around 20% situation, 10 to 20% situation, we are still unable to find out. So what might be the influencing the diagnostic block? Diagnostic block is again not foolproof. Some of you must be knowing that there is another called as a dual diagnostic block, and some other things are there, which is actually telling us that the diagnostic block, though it sounds very simple, that giving the local anesthetic is going to identify the as I told you, in 80% situation it can diagnose, but in 20% situation still some other factors are there which might be making the diagnosis a little bit more complex. So in the future we have to take care of the other factors which are making the diagnosis still more difficult. So this is the three important areas. So today, the present, what I'm going to discuss about the common pain generators. So how these patients presents, like when we are talking about the disc as pain generators, we must be knowing that what are the different pathological conditions which make a normal disc into a painful disc. What are their clinical features? How to make a diagnosis? So in that way, we'll be discussing. And then the next Sunday, we'll be summarizing all those things. So the pain generator concept, what can be a pain generator? To be a pain generator, a structure must be having a nociceptive innervation. It must be having a nerve, and then only it can be a source of pain. And this nerve can be a normal anatomical physiological nerve, or sometimes it can be a pathological nervation. Like, I'll be very short, very soon I'll be giving the example of the disc innervation. So when I'll be talking that normal disc, normal healthy disc, there are no nerves inside the disc. Only the outer one third of the annulus is having the nerve supply. But in degenerative disc, in pathological disc, this nerves grows in. Last year I was talking about the neural plasticity. The pains nerves are not rigid fixed structures. The nerves are changing, and one of the very important feature of the nerves is that their axons and dendrites are growing. Cell bodies are not increasing or decreasing in number, but the axons and dendrites can grow and can innervate the area which was not normally normal physiology and anatomically they was not innervated, but now in pathological conditions they might be innervated. So whatever it is, whether it is a normal physiological nociceptive innervation or whether it is in pathological, whatever might be, but it must be having some nerve supply. Otherwise, it cannot be a pain generator. So that is the concept. And if we are giving the local anesthetic in that, the structure, in that now or in that structure, the pain should be relieved, pain should be reduced, and that is how we can identify a pain generator. So what are the causes? So these are the 8 important areas. One is disc. Disc is the most common pain generator. If you're taking the whole of the population, the most common causes of back pain is because of the disc related pain. Then second is your facet joint. And facet joint is particularly the commonest cause of the pain if we are taking only the elderly population. The sacroiliac joint, third common cause. The myofascial pain, the fourth common cause, or maybe some say some literature, recent literature is telling no, muscle pain can be the commonest. Then comes the ligament, then comes vertebral body, a lot of bursas, the ligaments, hip joint is also there. Hip joint also must be included in the evaluation of the back. So all these things I'll be just quickly going into the structures, and I'll be discussing about the very briefly about the normal anatomy and then the pathological process, and then that how those pathological conditions are presenting clinically. That means what are the clinical features of those particular conditions. So two questions must be asked. One, where? Means where is the pain generated? Who is the nociceptive source? And second important part is also very important. That means why that particular structure has been converted into a pain generator. Say for example, if we're talking that a facet joint is the source of the pain, it is the diagnosis of the back pain is facet joint arthritis. The very important question will be coming, what kind of arthritis is it? Normal facet joint should not produce pain, but why this facet joint is a painful facet joint? So is it a degenerated facet joint? Is it a inflamed facet joint? Is it a infected facet joint? Is there any trauma in the facet joint? Is there any malignancy in the facet joint? So these are the common question which is coming under the heading of why. That means where is the pain generator? Which anatomical structure is the source of the pain is the first important question. But the second important question, very relevant, is your why. Means why that particular anatomical structure has been converted into a pain generator. So now the first, what we are discussing about the disc as pain generator. So the question is the where. If it is a disc, the second important question which comes that why. So three important pathological conditions might be there. One is called internal disc disruption. Second is called the disc prolapse. Remember, not all disc pathologies are disc prolapse. This is one of the very common mistake done by almost all of us. So whenever somebody is having the back pain, we start telling that okay, disc prolapse is the commonest cause of the back pain. But we have to remember that is not the commonest cause. And in many situations, the MRI says there are some disc prolapse, there are some disc pathologies, but in reality, that was not the source of the pain. So in these connections, I must be telling this. Maybe in our subsequent many times we'll be talking these issues again. So it was a study which was done in early 90s when MRI was very new. What was done in this study that this patient, not patient, sorry, some person, normal person, middle-aged. So they was taken in this study, they never ever had any back pain or leg pain. So the inclusion criteria was the healthy individuals who never ever had any back pain. And then MRI was done. And do you know what was the finding? Finding was 50% of them was having the disc collapse, and 28% of them was having a large extruded disc. So who never ever had any back pain. That means the disc collapse by MRI should not be jumping to treat it unless it is matching with our clinical evaluation. So clinical evaluation should be very, very important. If MRI is matching with that, then only we should be giving importance, otherwise not. So you must be very strong in assessing, making your provisional diagnosis based on your history and clinical evaluation. So going back, disc collapse, the last line what you say is disc collapse is the least common cause of back pain. Disc collapse commonly causes leg pain. In the lumbar area, disc collapse commonly produces leg pain, not the back pain. It can, but disc collapse most commonly causes the leg pain and canal stenosis. We'll be discussing all these things right now. So why? There are three important reasons why a disc can be producing back pain. So now, let us quickly go into the structures. We know that the disc has three important components. One, the most important component is your annulus. So annulus are the very tough fibrocartilaginous structures. They are like a boundary wall and not a single boundary wall. Annulus are the layers. They are called lamellae. 15 to 20 layers of or lamellae are there in the annulus. Fibrocartilaginous, they stand and they are not allowing the two vertebral body to come closer. So this vertebral body and this vertebral body should be trying to come closer because the body is wet. But this annulus stands tough. And again, another very important thing is you see lamella, one layer if it is like that, next layer is like this. So they are reinforcing in that way. And the disc height, again remember, the disc height is given by the annulus, not by the nucleus. So what is nucleus pulposus? Nucleus pulposus is a soft gel-like thing inside the disc. They do not contribute to the disc height much, very minimal. The most important contribution of the disc height is by the annulus. And the third important structure is the end plate, cartilaginous end plate above and below. So these are the three important component of the disc. And again, I'll be just going into the very little bit about the anatomy and physiology about all these three structures. So I'll be starting first with nucleus pulposus. Just now, as I told, that the nucleus pulposus is a soft gel-like thing inside. So nucleus pulposus. So nucleus pulposus. So what is important about the nucleus function of the nucleus pulposus? That they gives the pliability, means spine is moving. Why? Because it is made up of small pieces of bone, and in between there are discs. So this pliability or flexibility of the spine is because of the nucleus pulposus. So what are the components of the nucleus pulposus? Nucleus pulposus has some solids and have some water, and the water is about 80%. So 80% of the nucleus pulposus is water. Now the question will be coming, how this water is retained inside it? Means why the water is not diffusing out? The answer is, if you're remembering the analogy with the blood, what happens in the blood? In the blood, we are having the plasma protein. In the blood, we are having the plasma, means water. And that water is there because of the plasma protein. Otherwise, if the plasma protein is less, what happens? This water diffuses out through the capillaries. So, you know the different conditions when there is severe anemia, when there is, the nephrotic syndrome, any causes which causes the severe hyperproteinemia, the water diffuses out. Or even if the capillary pressure is increasing, like in eclampsia, preeclampsia, what is happening? There also the capillary pressure is increasing much, and the water diffuses out through the capillaries, and there is tissue edema. That means whether the intravascular compartment is having the sufficient water, how it is determined? Amongst the different factors, the most important factor is the proteins, plasma proteins. So plasma protein gives the oncotic pressure. So basically, it's a fighting between the two important, the pressure acting in opposite direction. So one factor is the oncotic pressure exerted by the blood plasma protein that is trying to force the water inside, and another factor which is trying to drive the force out is the hydrostatic pressure, the given by the blood pressure. So that the hydrostatic that is trying to force the water out. And the fighting between these two is going to determine in which direction water is going to move. So here plasma protein is holding the water. Same way here we are also having the two important factors, two important forces in the opposite direction. One which is intradiscal pressure. So intradiscal pressure is trying to force the water out, and the oncotic pressure inside is trying to hold the water. So how this oncotic pressure inside the disc is maintained? By the large proteoglycan molecule. So how from this proteoglycan molecule is coming? It is coming from certain cells, chondrocytes inside this nucleus pulposus. So inside the nucleus pulposus, there are certain chondrocyte cells which are manufacturing these proteins, glycoprotein molecules. And these are the large glycoprotein molecules. There are 4 or 5 different types. The most abundant type is your aggrecan. This is one of my very favorite MCQ question. So the most abundant glycoprotein molecule inside it is your aggrecan. So these aggrecan molecules is actually giving this oncotic pressure and trying to hold the water. So remember these things, and very important things, another very important things to remember, that our interdiscal pressure is going to fluctuate depending on our posture. So when you are lying down, our interdiscal pressure is very low, close to zero. Not exactly the zero, because our spine is the curved structure, it's not a straight. So even if when you are actually lying, even then there is some interdiscal pressure. So but it is very minimal when you're lying down. When you're standing, interdiscal pressure increases. When you're sitting, interdiscal pressure is stable, higher than the standing posture. And if you're sitting and bending forward, then interdiscal pressure goes very high. So that means interdiscal pressure is not a fixed one, constant one in any individual person. So in the whole of the day, your interdiscal pressure is going to fluctuate depending on our posture. And what you have to remember, that this interdiscal pressure is the least in the night. So whole day we are sleeping on the bed. So interdiscal pressure is very minimal. And as we are telling, it is the fighting between it is the product between the oncotic pressure and the interdiscal pressure. So if we are lying whole day, interdiscal pressure is very low and our oncotic pressure is higher, what will happen? Our disc will be swelling up. That means if we are looking about the hydration of the whole day, you will see that the hydration is your maximum early in the morning. And you might be knowing that our height has a diurnal variation. That means our height is not same in the early in the morning and the end of the day. So we are few millimeter, not few centimeter or inches. So few millimeter taller in the early morning. Why? Just now, because I told you that the nucleus pulposus contributes to the disc height very minimally, not much. And that is the reason why the whole night sleep, when the disc nucleus pulposus is swelling up, because the interdiscal pressure is less whole night, and we are becoming taller by few millimeters. So this is nucleus pulposus giving how the hydration is maintained. Now the very important part you have to remember, that the conditions, two conditions. One condition is called the aging of the disc. Another condition is called degeneration of the disc. So what is aging of the disc? Aging of the disc means it is the dehydration of the nucleus pulposus. So when you are growing older, what happens? Like any cartilage or like anything. So it chondrocyte cells starts going to reduce in number. So if the chondrocyte cells are less in number, what will happen? Then less amount of the glycoprotein molecule will be synthesized. So what will happen? The oncotic pressure will be less. So what will happen? The interdiscal pressure will be going higher than the oncotic pressure, and the disc water will be gradually diffusing out. So if you are comparing a disc in an individual in 24 hours, what we'll see? Early morning disc is better hydrated than in the end of the evening. And now, if we are comparing the disk of different two individuals, one is 20 and another is 80 in the early morning, what we'll see that in 80 years, the disk, almost all disk, even if after the full day's rest, full night's rest, still it is looking very black. Why? Because chondrocyte cells are already dead. Most of the chondrocyte cells are dead and not there. So there is no one to produce the aggregate molecules. So interdiscal pressure, whatever it is, still it is less than the oncotic pressure. So the water is not there inside the disc. And this is not going to produce any pain. Remember it. This is again a very common mistake done by almost all of us. That whenever we look at a disc which looks black on MRI, we try to say that the disc is dehydrated. That's fine. But this dehydrated disc is not going to produce any pain unless there are other pathologies there. So the black disc or degenerated, dehydrated, degeneration and dehydration is not same. Dehydrated discs are not going to produce any pain. But how it is affecting physiologically? If the disc is dehydrated, then the flexibility or pliability of the disc is less. That means our spine becomes stiffer. So if you are asking 80 years of people, unless he is having regular exercises, if you're asking to touch his feet, he might not be able to do it. Mostly cannot do it because spine has become stiffer because of the dehydration, because nucleus pulposus don't have much water. But if you're asking to touch the feet of an 20 years, he can easily do that because his disc has a lot of water. Disc is much more pliable. Disc is much more softer. So this is about the nucleus pulposus. So nucleus pulposus, aging process. Remember, the aging process of the disc affects primarily the nucleus pulposus. How? It becomes dehydrated. What is called degeneration then? Degeneration of the disc affects the nucleus, not the nucleus pulposus, it affects the annulus. First, let us talk about the functions of the annulus. As I told you, the most important functions, because there is a tough boundary wall, different layers are there. So they are giving the disc height. That is very important function of the annulus. But another very important function is is there any blood vessels inside the disc? I just told that there are no nerves in normal healthy individual. The nerves are there only in the outer 1/3 of the annulus. Inside, there is no nerves. Same way, you have to remember that inside the disc, there are no blood vessels as well. So the blood vessels are there only the outer 1/3 of the annulus and outer 1/3 of this, of this cartilaginous end plates as well. So if you're asking how the nutrition is actually supplied to the whole of the disc, how the chondrocyte cells inside the nucleus pulposus is surviving without oxygen, without the nutrients, the answer is this oxygen and the nutrients comes by diffusion from the periphery of the annulus to the center of the disc. And here the driving force is your fluctuating interdiscal pressure. So again, very important, very important concept. The change of the concept with earlier 20 years back and now is that earlier, suppose somebody is having the back pain. So what was the most common treatment done by us? We was forcing this patient to take the bed rest. Strict bed rest for 3 weeks. This was the earlier treatment. And what we are doing? We are basically forcing the disc to degenerate it further. That means if we are keeping the disc pressure constant, either at high level or at low level, whatever it might be, if the disc pressure is constantly the same without without any fluctuation or little fluctuation, so what will happen? The nutrients will not be nicely going inside. Oxygen will not be diffusing nicely inside. So the chondrocyte cells will start dying. So we do more harm if we are giving strict bed rest in a patient who is having the back pain. So this practice is nowadays abandoned. Nowadays, more than 2 or 3 days bed rest are not recommended by almost all professional societies. They do not recommend the bed rest for more than 2 or 3 days. So why? This is again very important that to remember that the disc pressure fluctuation is very important for having a healthy disc. So another very relevant question here, that earlier we was having the ergonomically designed chair, you know, to have a healthy disc, healthy back. But this concept is again obsolete. Why? Because if we are asking that how or what is the interdiscal pressure when you are sitting straight, the interdiscal pressure is little less than when you are relaxing and bending forward and sitting. So which posture is the best posture? Answer is the change of the posture. I mean, sometimes you sit straight, sometimes you just lean forward, so sometimes you move. So that movement is going to change the interdiscal pressure. And this change of the interdiscal pressure is the driving force to drive the oxygen and the nutrients inside the disc. So the stick bed rest is abandoned. Even if, in chronic pain, back pain, we must not be using the brace or belt also. That is also not recommended. Why? Because if you're putting brace and belt can be used only for very short period in the acute back pain. But if that is used continuously for the over the period, what will happen? We are basically limiting the movement of the lumbar spine. And by restricting the movement of the back, what we are doing? We are also prohibiting, we are limiting the fluctuation of the interdiscal pressure. So what is the best way to keep our back healthy? We should be promoting, we should be encouraging the movement. So if you are moving, if you are flexing, if you are extending, if you are just changing the posture, so that is going to fluctuate the interdiscal pressure, and that is the driving force for the oxygen and the nutrients to go inside. So what I was discussing, annulus, very important. Number one, it is giving the disc height. Second, very important is it is the driving, it is allowing the oxygen and the nutrients inside. Now the third one, very important, again, I'll be discussing that in further detail in the further next slide, is the innervation. So this is the sympathetic, the chain. I'll be very quickly, briefly going into that. I'll be discussing this again, sympathetic chain, the last class when I'll be talking about the visceral innervation. But again, to understand the disc-related pain, we must be understanding very briefly about. I'll be talking about the sympathetic innervation, and then I'll be coming out the disc innervation, and then I'll be going to subsequent slides. So if we are talking about the sympathetic nerves, so sympathetic nerves can be efferent nerves, sympathetic nerves are afferent nerves. Sympathetic nerves are also called the thoracolumbar outflow because it is starting from T1 to L2. So if we are looking about this lateral horn, which is the source of the efferent sympathetic fibers, it is not there in the cervical area, it is not there in the lower lumbar area. It is only the lateral horn is, or lateral gray matter is there only in the thoracolumbar area, T1 to L2. So the efferent fibers are starting here. It is coming anterior horn, and then it is forming the anterior root or the ventral root, and then ventral and dorsal root is combining, and this is at the level of the neural foramen. Here the ventral and the dorsal, they are combining. After it comes out of the foramen, means here out of the foramen, they are going to divide into dorsal rami and the ventral rami. So dorsal rami is going to supply the again three branches: medial, intermediate, and lateral. Medial branch is going to supply the facet joints. Medial branch is going to supply the interspinous ligaments. So this is the medial branch. So this is not very important, which is a smaller branch. Then the dorsal ventral rami is the more important. It is mostly the motor. But there is a third division. This third division might be coming either from the ventral rami or from the nerve root, and that is very important. So this is this third, which is called the rami communicates fiber. So white rami and the gray rami. So white rami, I'm talking about the white rami because I'm talking about the L2, because lateral horn is there from the T1 to L2 level. So after coming out along the white rami, they are coming out. They're coming out and join the sympathetic chain. So this sympathetic chain are two in number. One this side, another is this side, and they are, when they are for joining the sympathetic chain, after joining the sympathetic chain, they have the three fate. Either some of the fibers are ending there, some of the fibers are going up, some of the fibers are going down, and at each level, now question is why they need to go up or why did they need to go down? Why they are not like the other somatic nerve root, which is segmental, which is dermatomal? Here, the sympathetic fibers are called the non-segmental, non-dermatomal because the first order neuron are not necessarily ending only at the same level. They can go up. Why they need to go up? Because cervical level, there is no sympathetic fibers coming from the cervical areas. As I told, it is only thoracolumbar. So cervical nerve root also needs sympathetic fiber. Where from they will be getting it? They will be getting it from the sympathetic chain. So once they join the sympathetic chain, so after joining there, some fibers end at the same level, some goes up, some goes down, and from each level, the sympathetic fibers, second order neuron are starting, and they are coming back, and they are going to the periphery. So joining here, some are coming back, cis gray and white are together, and then they go to the periphery, and some goes up at that level also. So if I'm talking about at the level of the cervical, then this part is not there. This part is not there. Forget about this part in the cervical area. So only, suppose this is your C5 nerve root. So they have only this is your gray rami. This is your white rami. White rami or gray rami are together. They might be inseparable. But if you are looking about the minor detail, so this looks white because they are finely, thinly myelinated. They looks gray because they are non-myelinated. This is the second order neuron and then goes to the periphery. So each nerve root have the sympathetic fibers either coming from the same level, or it might be coming from either above or below. Okay, we'll be discussing the sympathetic fibers in further detail when we're talking about the visceral pain. So now let me concentrate more on the disc, how the disc is innervated. So this goes here, and then what happens? This goes either up for the lumbar disc. Let us consider about the lumbar disc today. So going up, and then they find, the to go to some of the nerve roots, and then goes down. Sorry, if you're talking about the efferent fibers, they're coming down and they find the nerve roots and goes periphery. Now, when you're talking about the afferent fibers, the afferent is the opposite direction. So the fibers comes along with the nerve root, and then via the gray rami communicants, they join the sympathetic chain. And for the lumbar disc, they have to ascend up, and they can enter into the spinal cord only via the L2 and above, because L2, T1 to L2, we are having the connection with the sympathetic chain and the spinal cord. At all other level, there is no connection between the sympathetic chain and the spinal cord. That means if you're talking about the lower lumbar disc, then these fibers which are coming from the disc at the lower lumbar, so they have to ascend up along the sympathetic chain, and then they can enter. And then what are they happening? They are joining the other somatic nerve, and they join in the first order neuron ends. Their cell body is at the only one cell body has the dorsal root ganglion end here, and the second order neuron is spinothalamic point and goes up. So now I'll be now concentrating. So keeping these things in our mind, I'll be now concentrating on the disc innervation. So that first of all, as I told, that the disc innervation is by the sympathetic nerve. Earlier, it was thought that the disc has the dual nerves, anteriorly and laterally by the sympathetic nerves and posteriorly by the somatic nerve. This nerve is called the sinovertebral nerve. But nowadays, recent the studies with the immunohistochemistry has suggested and has proved that even the sinovertebral nerves, though it looks like a somatic nerve, it actually carries the sympathetic fibers. So the disc is more than 90% fibers are the sympathetic fibers. So now, how these fibers are actually taking the pain signals to the brain? So anteriorly and anterior. Let me take this laser pointer. So anteriorly and laterally, these sympathetic fibers from the outer 1/3 of the annulus, they join the gray rami communicants directly or into the sympathetic chain. And what happens? These fibers then carry the signals. It has to, if it is L2 or L1, fine. But if it is below that, they have to ascend up and find the L2, and then it will go here, and then it comes here, and then by the dorsal root, they'll be entering here, and then the spinothalamic tract, they'll be going up. Just think this one and this one. I have cut this and I have pasted here in the spinal canal. So then what happens to the posterior annulus? That is the most important area. Posterior annulus is having the network of the nerves, which ultimately forms the sinovertebral nerves. And then these sinovertebral nerves also comes to the foramen. So this is again a tricky question. If I'm asking, what are the nerves which passes the neural foramen. So answer will be the nerve root, exiting nerve root, and sinovertebral nerve. Many of the times we miss it. What are the second nerve which is actually crossing the neural foramen? That is your sinovertebral nerve. So this sinovertebral nerves comes out and it has three feet where it can join. Number one feet is it can join the nerve root, mixed nerve root. Number two feet is it can join the dorsal rami. And number three feet is it can join the sympathetic, the rami communicates fiber. But whatever is the fate, wherever it is ending, finally it is coming, the sympathetic fibers are ultimately coming here. And then it ascends up along the sympathetic chain, and then via the white rami at the level of the L2, it will be coming like this. So that means the outer layer is by sympathetic fibers, and this is the normal healthy anatomy. Now what happens? Suppose there is a, now I'm talking, so we discussed about the three important functions of the disc, of the annulus. One important function is it is giving the disc height. Second important function is it is supplying the nutrients. Third important function is it is holding the nucleus pulposus inside. Now it is also having the nerves in the outer layer. And if what is called disc degeneration? Disc degeneration means it is the degeneration or weakening of the annulus. What is the aging of the disc? Aging of the disc means the dehydration of the nucleus pulposus. So aging and the degeneration, you have to remember, they are the two very important distinct process. So pathological process, the one is aging process, is not pathological, and second is the degeneration, that is a pathological process, and that involves the annulus. So which layers of the annulus? As I told, there are 15 to 25 layers of the annulus. Which layers of the annulus? It is the inner layers. But again, remember that the disc degeneration always starts from inner layers of annulus. Why? Because outer layer has the abundant nutrients, oxygen. So they are very less likely to be degenerated. So inner layers of the annulus, there is no blood supply because only outer one third is having the blood supply. So that is the reason why the inner layers are degenerated. And if they are degenerated, means it is becoming weak. And if it is becoming weak, what will happen? Very important function of the annulus is to hold the gel inside. So if it is weak, if the interdiscal pressure is going high, then what will happen? There will be rupture, so leaking, there will be tear. So the nuclear material will start coming within the layer of the annulus. This is called, radiologically, this is called annular tear. And if this is coming within the layer of the annulus, what will happen? Body will sit idle? No. Body will try to repair it. And another very important thing you have to remember, that these glycoprotein molecules are segregated from the body's immune system by miles away, because only outer one third is the blood supply. Inside, then there are several layers of the lamellae of the annulus, and then we are having the nucleus pulposus. So from the fetal life, they are separated. They are not in touch with the body's immune system. So when they come first time with the body's immune system, they will be seen as a foreign material. So body, what will try? So body's nucleus material is coming towards the periphery. Our body will not be sitting idle. It will try to repair that weak part. How? By neovascularization. So blood vessels will be going in to repair that degenerated part, repair that annular tear. So the blood vessels will grow in. Along with the blood vessels, there is sympathetic fibers. Sympathetic fibers will grow in. And now one point will come when these blood vessels, body's immune system, will meet this nuclear protein, aggregates and others. And they will be thinking that it is a foreign material. So fighting, inflammation will start. And this inflammation will involve the sympathetic nerves as well. And sympathetic nerves, which was earlier not painful, sympathetic nerves which was not there inside the disc, now they are growing in and they are becoming the painful nerves. So what will happen? Anything which rises the interdiscal pressure is now going to produce pain. Earlier it was not going to produce any pain. Even if you are jumping, sitting, lifting something, bending forward, it was not going to produce pain. But now, because the sympathetic nerve is inflamed, it is sensitized, and now slight rise of the interdiscal pressure is going to produce pain. And this is called internal disc disruption. Radiologically, this is called annular tear or radiologically it is also called hyperintense zone, because if you are looking examining in this under the MRI, it will see that within the black layers of the annulus there are white areas, battlefield. Why? White areas is basically edema. In the MRI T2 weighted image, we see the water as white areas. So the white areas within the layers of the nucleus of the layer of the annulus is going to be there, which is called the hyperintense zone, indicating the battlefield, indicating the inflammatory areas. So this is going to produce pain. So now this internal disruption, what will be the clinical features? Very important thing is that this pain is mediated via the sympathetic nerve. So what is the difference between the pain mediated by the sympathetic nerve and the somatic nerve? So somatic nerve is having the strict dermatomal values. Pain is finely located, nicely located. If you're asking, please draw a pain map, patient will be able to do that. But if the pain is mediated by the sympathetic nerve, patient won't be able to do it. So patient will be telling this is the area, but cannot pinpoint. Okay. So if there is internal disruption, what will be the clinical feature? Number one is, very important thing is your history. History will be telling patient is younger. Why younger? Because disc nucleus pulposus must be fluid, must have water, then only it can leak. If the disc is, the person is older, 80 years, what will happen? Disc is already dehydrated, sorry. And if it is dehydrated, its fluidity is less, so it has less tendency to leak. So internal disc disruption is a disease of the younger, 20s, 30s, 40s maximum. After 50s, chances of the internal disc disruption and tear will be less, gradually less. But no it as a bar. Why? Because even if we see at 80 years somebody is having very black hairs, full of hairs, it can happen, but still chances is less. So internal disc disruption is a problem of the younger, 20s, 30s is the common stage. And patient will be telling that when I'm sitting, I cannot sit longer. When I'm sitting, what is happening? Interdiscal pressure is going high, and that is going to produce pain. Standing is less painful, but still there will be pain. Lying down relieves the pain. So this will be the history. Walking, patient will not be having much pain. Same. But what is very important is, walking is not going to produce leg pain. This is predominantly back pain, vaguely localized back pain. No somatic nerve is involved here. Vaguely localized back pain, and that back pain might be, from the center of the back, whole of the back, sometimes buttock, sometimes back of the thigh, but non-dermatomal. This is very important. Non-dermatomal, non-radicular. So it is a diffuse pain. So this will be the history. Very important. With the history only you can identify it. And then on examinations, inspection, palpation. On palpation, are you going to get any tenderness? Answer is no. Because disc is a very deep-seated structure. You cannot palpate the disc. You cannot palpate the areas of your pressure superficially, cannot transmitting any force inside. But sometimes if you are percussing, or sometimes like this, there might be some pain. But otherwise, the palpation is not going to elicit the pain in the internal disc disruption patients. Then, after the other test, almost all other tests will be negative. Almost all other tests. So, we tell these things very frequently, but that internal disc disruption patient, don't have any clinical signs positive. So, no clinical sign is the sign for the internal disc disruption. If you're examining everything, you are not going to get anything. That is going to tell us that this is internal disc disruption. Almost all tests will be negative. Some only thing is, when the patient is sitting for some time, 10-15 minutes, patient cannot sit further because of the rise of the interdiscal pressure is going to irritate the sympathetic nerves, sensitize sympathetic nerves inside, and that is going to produce pain. If you're asking the patient, please show your pain map, patient can't. If the patient is okay, show your pain with your finger, patient can't. So this is the most important history. So, and this is how I'm not going to go through the diagnostic part like discography and all those things we might be discussing in some other classes. But this is how an internal disc disruption patient is present. So now, what is the difference with the disc prolapse? So disc prolapse, what is happening? That the nuclear material is still further going out. So it is within the layers of the annulus and irritating the sympathetic nerves here. But when it comes out and if it is pressing this nerve root which is exiting or which is traversing inside, if it is going to compress here, so then what will happen? That is going to produce a radicular leg pain in the lumbar area, radicular leg pain, and that is called the disc prolapse. So the disc prolapse might be still having some of the back pain because of the irritation of the sympathetic nerves, because of the indentation of the dura here. But very important feature of the disc prolapse is that is going to produce a radicular leg pain, that is somatic nerve mediated pain. So pain will be very sharply localized. Patient will be able to show it is with their finger. Patient, that pain will be along some of the dermatome, and that pain is aggravated on walking. If the patient is having the leaking of the disc, even sitting is not going to produce pain. Sitting might be comfortable. Why? Because when they are sitting and with your hip flexed, knee flexed, then what is happening? Then your nerve root is basically relaxed. To relax the nerve root, if the knee is flexed, the hip is flexed, then the nerve root is getting relaxed. And in that way, we can, when you're sitting, the patient's pain might be less. Standing, walking increases the disc prolapse pain. But what is very important is pain is dermatomaly. Pain is might be having associated with the the weakness, because it is a somatic nerve. It is having the motor supply, so there might be some weakness of that particular nerve root. There might be some numbness supplied by that particular. So these all neurological signs might be there if it is a disc prolapse. So the disc prolapse, the most important difference is that internal disc disruption patients presents with the vague back pain, and disc prolapse patient presents with radicular dermatomally distributed leg pain with or without some neurological signs. So this is how a disc prolapse patient is present. Now the third important area, again you have to understand it very nicely, is the canal stenosis. So the spinal canal, what is the boundary of the spinal canal? So boundary of the spinal canal is anteriorly we are having the annulus and vertebral body. So this section is from the disc, if its section is taken from the vertebral body. So anteriorly by the annulus and the disc, and disc annulus and the vertebral body. Posteriorly by ligamentum flavum and lamina. Laterally by either by there is pedicle or there is open at the neural foramen. Posterolaterally by the facet joints. So this is how a spinal canal is formed. So the spinal canal can be narrowed by certain pathologies, and most common pathologies is starting with the annulus. So now, as I told, that the disc prolapse and the internal disc disruption, these are the conditions of the younger patient. Why? Because discs should be fluid at this time, liquid, more water. But when this person is growing older, then what will happen? Even if the annulus is weak, if the annulus is degenerated, still then the disc nucleus pulposus will be having the less tendency to come leak. What will happen? They will be bulging, be going. They cannot stand like this. They will be buckled, they will be bulged, and that the outward bulging of the disc is going to compromise the canal diameter by anteriorly. So bulging disc compromise, that is one of the very important cause. So here the nuclear material is not directly coming, but because the annulus is weak, so it is bulging, it cannot stand, it's buckled, it is bulging from anteriorly. And when the disc annulus is bulging, the two vertebral bodies will be coming closer, because that is going to give the disc height. And if the two vertebral bodies are coming closer, what will happen to the lamina? So the two lamina are also coming closer. Who are there in between the two lamina? There is ligamentum flavum. So they also come closer and they'll be folded and they'll be protruded from posteriorly. And this is called ligamentum flavum hypertrophy. So it starts with the disc pathology anteriorly. Now second important changes is your ligamentum flavum hypertrophy. And the third part is the facet joint complex also gets degenerated. Why? Because it is supplied by the same segmental arteries. So disc degeneration, facet degeneration goes hands in and more than 50% situations. And if the facet joint is synovial joint, if it is degenerated, there will be osteophytes, hypertrophic margins. So that will be compromising the canal diameter from the posterolaterally. So the canal stenosis is basically have the three important components. One is bulging annulus from the anteriorly, the ligament from the hypertrophy posteriorly, and posterolaterally the fascial joint hypertrophy. So if the gradually the spinal canal diameter is getting compromised, then what will happen? What will be the clinical process? Please mute yourself. So what is going to happen? So the most important content of the spinal canal is here the soft, which is first affected is your blood vessels. So if it is acutely narrowed, that condition is called as Scott-Iconus syndrome. I'm talking about the lumbar area, lumbosacral areas. But if the spinal canal diameter is gradually over the period, if it is getting narrowed, what will happen? Then the blood vessels will be getting compressed. So the blood vessels, you're supplying the nerve roots, the the spinal cord will be getting compromised. And what will happen? Then because of the less blood supply, the nerves will suffer from ischemia, and it depends on the posture. So when we sit, so try to understand that when you sit, we are flexing forward. And if you're flexing forward, these two lamina will be getting separated and the ligamental flap will be stressed and the canal diameter will be increasing. So in the spinal canal stenosis, very important to remember to understand that when you flex forward, that means like when you are sitting, then the two lamina will be getting separated, the ligamental flap will be stressed and the canal diameter will be increasing, and patient will not be having any symptoms. But when the patient stands, then the two lamina comes closer, the the, the ligamental flap will be pushing the dura, that causes the back pain, axial central back pain, like the disc disruption. So this pain is again vaguely localized. Why? Because dura is again supplied by the sympathetic nerves, not somatic nerve. And the patient, most importantly, apart from the back pain, the patient will be having the leg pain. Why? Because those nerves, those blood vessels were supplying the nerve roots. So that will be compromised. And patient, if it is walking, again, that is going to produce more pain. Why? Because the nerve, when they are working needs more oxygen supply. So that oxygen supply cannot be fulfilled, their demand cannot be fulfilled because of the compressed blood vessels. So the nerve will be suffering from the ischemia, and that is going to produce the leg pain. And this is called neurogenic claudication. So not only just pain, patient will be having the other features of the neurogenic claudication, like there'll be some tingling sensations, there will be some numbness, some heaviness, weakness. So these all are going to be produced in the spinal canal stenosis. So the sitting is comfortable, sitting to standing producing the back pain, and on walking, they'll be having the neurogenic claudication. This is the presentation of the spinal canal stenosis. So the disc pathology presents in, remember the spinal canal stenosis is because of the other, like a slowly growing tumor, some fibrosis, listhesis on the one vertebral body moving over the other. There are other causes of spinal canal stenosis, but the most common causes of spinal canal stenosis starts with the disc degeneration. So these degenerations can be presented clinically by the three different entities. One is the internal disc disruption that produces the back pain. Second is your disc prolapse that produces your radicular leg pain. And third one is the neurogenic claudication, that is the spinal canal stenosis. So coming back to our, this thing. Sorry, what is the next slide? So disc spin generator, so it can be internal disc disruption, that presents with the back pain. It can be disc prolapse that presents at the radicular leg pain, and canal stenosis that produces the ischemic leg pain, means the claudication. So these are the three important feature that it mentioned: back pain on sitting, leg pain on walking, and claudication on walking. These are the three important, most important clinical feature if you're talking: back pain on sitting, disc prolapse, leg pain, radicular leg pain on walking, and here neurogenic claudication on walking. These are the three important clinical features of these three important, the disc related pain. Next, very important is your facet joint. So facet joint, where is it? it is the posterolateral part. There are two facet joints on either side. So what are the functions of the facet joint? Very important function of the facet joint is it gives the stability of the spine. One vertebral body is not slipping over the others. Why? Because of the facet joint. And facet joint is not a plane. One is concave, another is convex, so that they are fitting very nicely and not slipping. So the facet joint gives the stability, you have to remember. And facet joint is supplied by somatic nerve. Somatic nerve, one is coming from the same level, another is coming from the above level. So these are the nerve root, ventral rami, dorsal rami. Dorsal rami have three branch: medial, intermediate, lateral. Medial branch supplies the same level facet joint and goes down to supply the next level facet joint. So one facet joint is supplied by the same level and one level above. That means if it is L4-5 facet joint, it is innervated by L4 and L3. Means medial branch is coming from the dorsal rami of L3 and L4. So facet joint pain, how this patient will present? Again, as I told, facet joint is the most common cause of the back pain in an elderly person. In elderly population, this is the most common cause of the back pain. So how this patient will present? They'll be telling that sitting is comfortable. Why sitting is comfortable? Because when you sit, we flex, and this facet joint is in the posterolateral part. So there will be unloading of the facet joint. So how the facet joint can be unloaded? By flexing forward. How the facet joint can be loaded? By extension. Facet joint is having another very important function is rotation. So rotation is and lateral bending. Here the facet joint is pivot. So these three movements, extension, lateral bending and rotation, facet joint is pivot. And these three movement facet joints are loaded. That means unloading by flexion, loading of the joint by lateral bending, by rotation, by extension. So if the facet joint are loaded, facet pain will be aggravated. So sitting, no pain. Sitting to standing, patient will be having some pain because it is from unloaded to loaded position. If you are asking the patient to rotate or extend, patient will be having aggravated the back pain. So what will be the clinical feature? Sitting is comfortable, patient is elderly, patient will be telling, okay, at night, when I'm turning the bed from, turning on the bed from one side to another side, the rotation, it is painful, cannot turn nicely. Sitting to standing is painful. Walking, will it produce pain? Answer is, walking is not going to increase the pain. Why? Because again, we have to remember that any joint pain, initial part of the movement is painful. After that, gradually pain reduces. This is the feature of any joint pain. So facet joint pain also, on walking, initial part will be painful. After that, pain will be gradually reduced. So this is the feature of the facet joint pain. So it will be dermatomal or non-dermatomal. Again, patient will be having the back pain, which is sharply localized because it is somatic nerve. But patient might be having a leg pain, which is less, which is mild, which is referred pain, that is non-dermatomal. Facet pain has two parts. One part is local pain, that is by the somatic nerve, that is well localized. And the second part, which is the referred pain in the leg, which is non-dermatomal, and possibly, the second leg pain, radiating leg pain might be because of the sympathetic nerve. Because facet pain is mostly sympathetic somatic nerve, but it also have a very mild, very small sympathetic fiber as well. So, will there be any neurodeficits? Answer is mostly no, because facet pain is because of the facet joint degeneration or inflammation that is not going to produce anything on the any pressure on the nerve root. So there will be no neurodeficits. There will be pain, leg pain will be non-dermatomal. So facet has a pain generated, these are the clinical features. And again, as I told you, why facet joint can be painful? It can be because of the degeneration, it can be because of the inflammation, it can be because of the trauma, it can be because of the other rare causes of the malignancy and other things. So these are extremely rare. The most common, these are the degeneration and the inflammation. So facet pain again, let me repeat, elderly population, sitting is comfortable, sitting to standing is painful, turning on the bed is painful, walking gradually reduces the pain. Pain is mostly on the back. Pain might be having some in the leg, but that is mild, that is non-dermatomal, because leg pain in the facet joint pain is a non-dermatomal. And facet pain might be because of the degeneration, inflammation, or trauma. So now, third important cause of source of the pain is here. These are the features. as I mentioned, predominant back pain is non-dermatomal leg pain, pain relieved on sitting and bending forward, pain increased on extension, lateral bending and rotation, pain decreased on walking, and there will be no neurodeficits. So these are the short clinical features of the facet pain. Now come to sacroiliac joint pain. So sacroiliac joint is a very large joint. Sacroiliac joint has two parts. One is synovial part, another is the fibrous part, and it is having an innervation from very wide area from L4 to S4. Mostly it is S1, 2, 3, but it also have the fibers coming from L4, 5 and also from the S4. So what is very important that this network of the nerve comes mostly from the lateral. Just now I told that the nerve root has the lateral, intermediate and medial branch. Medial branch is going to supply the facet joint, and lateral branch goes laterally to innervate the sacroiliac joint. So this is the most important. 80% of the SI joint innervation is by the lateral branches of the nerve roots. But sacroiliac joint also have some innervation from the ventral rami, which comes through the pelvis, anterior part of the joint, which is we cannot access it. So sacroiliac joint pain, again, you have to remember how this sacroiliac joint is getting loaded and unloaded. So when you sit, sacroiliac joint is loaded. That means how the patient will present. The patient will be young or elderly, both is possible. When this is inflammation, you have to remember sacroiliitis is another very important feature of the ankylosing spondylitis or other kind of inflammatory spondyloarthritis. So it can be, these patients are male, mostly male and young, 20s, 30s. So it is possible to have the sacroiliac joint pain in the younger, or more commonly, it is the elderly, like facet joint. The sacroiliac joint can also be getting degenerated and can be a painful sacroiliac joint. So the age can be both, either young or elderly. They will be presenting with the buttock pain, mostly with the somatic nerve. So pain is well localized. Pain will be aggravated on sitting. Sitting to standing will be less painful because loaded to unloaded position. Walking will be gradually reducing pain because it is a joint pain. The pain is predominantly in the lower back and the buttock, but it can also have some radiation in the back of the thigh. But that radiation is like that of the facet joint, non-dermatomal radiation, no neurodeficits. So these are the features. And for the sacroiliac joint pain, there is a long list of provocative tests, special clinical tests. We'll be discussing it in the next class. That those provocative tests can aggravate the facet joint pain. Like Bhattad test is one of the very commonly done tests. Sacral thrust test, many other tests we'll be discussing. So this is how we can make a diagnosis of the sacroiliac joint pain. So the clinical features, buttock pain or the lower back pain, which is well localized because it is somatic nerve, with a non-dermatomal leg pain. The pain increased on sitting and relieved on standing or walking, not fully but partially, and there will be no neurodeficits. Then next very important part is your muscle as a pain generator, skeletal muscle as a pain generator. So we know that in the back there are a lot of skeletal muscles there, and three important muscles you always remember. Because why? Because these muscles are very close to the nerves. One of them is piriformis muscle. So piriformis muscle, they are, let me go to this next slide. Sorry. No, this picture is not there. Okay, next class I'll be trying to have this picture. So muscle as a skeletal muscle have very few the nociceptive nerves, but in certain conditions like repetitive stress injury, prolonged muscle spasm, sometimes malignancy, all these things can cause the skeletal muscle as the source of the pain because of certain changes. This is the area of the skeletal muscle is called the trigger zone or trigger point or trigger area. And if you are stretching that skeletal muscle, it is going to aggravate the pain. And these skeletal muscles are going into spasm. The painful skeletal muscles are going into the spasm. So now the few muscles are important. Why? Because when these muscles are going to the spasm and they're contracting, they can cause pressure on the adjacent nerves. Like one of them is piriformis. So piriformis muscle is originating from the lateral part of the sacrum, inserting into the greater trochanter. And when it contracts, it can produce pressure on the sciatic nerve. That means this piriformis syndrome patient can present with the buttock pain, which is aggravated on cross-leg sitting. Cross-leg sitting means you are putting one leg over the other. If you're putting the one leg over the other, you are basically stretching the piriformis muscle and pain might be aggravated. So cross-leg sitting is one of the very important clinical feature. Tomorrow we'll be discussing all these things again. No, not tomorrow, next Sunday, sorry. So the cross-leg sitting is going to stretch the piriformis muscle and they can be painful. And patient might be having the buttock pain as well as these patients might be having the radiating leg pain because of the compression of the sciatic nerve. So that is how this is important because it mimics closely the disc prolapse. The next two important muscle is one is your psoas that forms the anterior boundary of the lumbar plexus. Another is your quadratus lumborum that forms the posterior boundary of the lumbar plexus, posterior of the of that. So if there is myofascial spasm or myofascial pain of the psoas, what will happen? Patient, when the psoas is contracted, patient will feel comfortable on bending forward because psoas is the contractor of the causes the flexion of the hip and the lower lumbar spine. So if that is flexed, that means when you are sitting, our hip is flexed or lower lumbar, the vertebrae are flexed. So that is a very comfortable posture. But when the patient will be standing, pain will be aggravated. When the patient will be extending, pain will be aggravated. And it can produce the radiating pain because of the compression pressure on the lumbar plexus. Same way, quadratus lumborum is an extensor. Quadratus lumborum originates from the 12th rib inserted into the and the transverse process inserted into the iliac crest. That is an extensor. That means sitting will be painful if the quadratus lumborum is going to be a pain generator. So again, they are the muscles, three muscles, and repetitive stress injury can be one of the very important reasons for this pain in this patient. Ligaments, certain ligaments like interspinous ligament and some other ligaments can be because of the enthesitis. What is enthesitis? What is enthesis? Enthesis is the soft tissue around the insertion of the ligaments and the tendons and the capsules. So these soft tissues sometimes inflamed, particularly in spondyloarthritis like ankylosing spondylitis. So that can be a painful condition. So the ligament sometimes becomes the source of the pain. Then is the vertebral body, particularly if there is a vertebral body fracture. And this is not uncommon in an elderly population when the vertebral bodies, the bones are becoming very fragile and that can be fractured and that can also produce pain. We have to remember that the vertebral body innervation and the disc innervation, whatever I have discussed today, are almost similar. So vertebral body pain also is a diffuse pain, back pain, and there will be non-dermatomal pain if particularly the anterior part of the vertebral body is compressed, fractured. And these patients are also having the pain on sitting or standing. Then is sometimes some of the bursas, particularly in the buttock and the hip, there are a lot of bursas are there, and hip joint itself sometimes can be a pain generator. So what was important that, as I told, I started this with this slide. Last part, still I'm not going to discuss further about all those things. I might be discussing on the subsequent classes. So very important part to evaluate the back pain is we have to understand each pain generators, and by clinical evaluation, by history, we can understand these pain generators. But sometimes if we cannot, then ultimately we might be confirming our pain generators with injection of the local anesthetic. So with this, I'm stopping and I'm inviting questions from you. If you have any questions, you can ask me. And then on the next Sunday, we'll be going for further evaluation, particularly with this, the back pain, the different causes. Next class, I'll be discussing about the red flags, and then I'll be also discussing about the different clinical tests to make a diagnosis. So you can unmute yourself and you can